Adult cardiac arrest is typically a heart problem, a primary pump failure. But in a newborn, the code is a lung problem. The heart slows because the lungs have not yet transitioned from fluid to air, depriving the body of oxygen. This physiological difference is why neonatal resuscitation follows one specific rule. If you fix the lungs, you fix the heart. This chart shows the happy path used during the initial assessment at birth. Providers look for 3 signs. Is the baby term? Are they breathing or crying? And do they have good muscle tone? If the answer to all 3 is yes, the baby stays with the mother. Their trajectory in those first minutes of life follows these observable signs of respiratory and neurological transition. But if the answer to any of those 3 questions is no, a 60-second clock begins. This is the golden minute. In this window, the team performs the initial steps: warming, drying, and stimulating the infant, while positioning the airway to clear secretions. At the 1-minute bracket, if the baby isn't breathing or heart rate is under 100, the provider pivots. The yes path leads to positive pressure ventilation. PPV is the most important step, directly addressing the root cause, lungs failing to oxygenate blood. At this stage, a major friction point often occurs. The heart rate may continue to drop while you are bagging the baby. In a high-stress delivery room, the provider's instinct is to start chest compressions. You must resist that instinct. Instead, use the MRSOP sequence to check the mask, the head position, and the airway. You have to fix the ventilation first, because the heart rate is likely dropping because air is not actually reaching the lungs. Advancing further down the algorithm is futile if the airway is blocked and the lungs are not visibly expanding with every breath. Let's test this in a clinical scenario. Exactly 90 seconds have passed. You are providing effective PPV with visible chest rise, but the heart rate is at 50 beats per minute. What is your next move? This section of the flowchart provides the answer. Because the heart rate is under 60 despite effective ventilation, you move to C for circulation. You now begin chest compressions. Newborn compressions use a 3-to-1 ratio, 3 rapid compressions followed by 1 breath. Providers count out 1, 2, 3, breathe, to ensure oxygen continues moving into the lungs while the heart is manually pumped. Looking at the very bottom block of the chart, we see the absolute final step. If the heart rate remains under 60 after a full minute of coordinated compressions and breaths, you move to D for drugs and administer epinephrine. Compressions and drugs are last resorts for a neonate. They act as support systems that fail if the primary respiratory baseline is not established. You do not need to memorize every box on a complex flowchart. You just need to understand the linear timeline of neonatal respiratory distress. The process is a simple sequence. At 0 seconds, evaluation. Within 60 seconds, finish the initial steps. If the heart rate is under 100, start PPV. If it drops under 60, start compressions. And if it stays under 60, administer drugs. The rule of this ladder is simple. Never step up to circulation until you are certain you have mastered the breathing steps. In the delivery room, mastering the airway is mastering the code. Focus on the lungs, and the rest of the algorithm will follow.